Hi, my name is Casey Glass, and I'm the Ultrasound Director for the Center for Experiential and Applied Learning at Wake Forest School of Medicine. And this is a procedure module on ultrasound-guided peripheral IVs. Overall, we'll go over the reasons to place an ultrasound-guided IV, as well as the equipment and resources that you need to complete that, and how to do it with both in-plane and out-of-plane technique discussion. So generally speaking, we place ultrasound-guided IVs because patients require IV administration of either medications or fluids, and normal attempts at peripheral IV placement have failed. There should not be any existing indication for central venous access or more durable access. If there were, those routes of administration would be preferred. There may be reasons to avoid placing an ultrasound-guided peripheral IV. If there's a reason already that you shouldn't be putting IVs in that limb, that would also be a contraindication to an ultrasound-guided IV. It is unwise to stick through infected areas or areas that are significantly traumatized, or if there's local tissue derangement, for example, from a hematoma from a previous IV attempt. Also, there should be consideration given to whether or not a patient will need more durable access like a PICC line or central line. Placement of ultrasound-guided peripheral IVs can cause some mild thrombosis of veins, and so it can make those veins unavailable for those attempts later. It's important to maintain good infection control practices outside of emergency settings for procedures which puncture the skin. That would require a probe cover for the ultrasound probe to prevent it from becoming contaminated with body fluids, and typically we use sterile ultrasound gel to stick through for these procedures. So what sorts of things do you need to have together to go ahead with this procedure? Overall, you need the same materials you would use for a standard peripheral IV. Although we do use a probe cover for ultrasound-guided peripheral IVs, it is not otherwise a sterile procedure. It can be done clean, just like we would with a normal peripheral IV insertion. You do, again, want sterile gel and a probe cover. In our institution, those come together in a package. If you are unable to find sterile gel otherwise, the surgical lubricant packs that we use for thermometers and other situations that need lubricant are also sterile. If you had to improvise a probe cover, many institutions use a clear tegaderm or other similar plastic barrier to provide protection for the probe from body fluids. It's very important to identify the longest available angiocath you can obtain for this. Procedure failure and early extravasation from the catheters are most significantly associated with catheters which simply come out of the veins. And so the longer the catheter is, the more of the catheter will be in the vein, the less likely it will back out of the vein and cause extravasation. For example, in our particular institution, we use a longer version of our normal retractable angiocath. Our normal catheters are about 3 centimeters long, and our longer versions are about 5 centimeters long. In the pediatric setting, usually you simply have to find the longest catheter, which is small enough to fit in your patient, and I will typically use a 22 for those patients if I can find a vein that will accommodate it. Most oftentimes, you'll have a machine with several different probes available to you. The probe of choice will be the linear probe. It should look something like the image that I have in front of you. It often is flat, rather narrow, and we prefer it because the high frequency beams that it uses to make the image give a lot more image detail and resolution, which means that in turn, it'll be easier to see the needle tip. Machines also typically have an ability to choose a preset that will make it easier to see the blood vessels and the needle tip. Sometimes when we're looking at arms and legs, we would use a soft tissue preset, and those presets give a lot of range of grays through the image. So if I'm trying to find a nodule or a mass, having that variety of grays can be useful, but it's not so helpful for vascular access procedures. So for the most part, we're going to want to choose the vascular preset. It may be labeled as artery or vein on your particular machine. It's going to give you a very contrasty or black and white image, and that will really help those veins to pop out for us. As we're getting ready to do the procedure, we want to kind of just think about how we're going to arrange ourselves for it. I recommend holding the probe with your non-dominant hand. So if you're right-handed, that would be your left hand. Of course, if you're left-handed, that would be your right hand. And I recommend holding it a little bit like a pencil. So you want to kind of be able to plant the side of your hand on the patient's body so the probe doesn't slide all over the place, and then hold the probe upright between your thumb and index fingers. And that will give you some better control over it. It's also very important to position the patient appropriately so that you maximize your chances of success for the procedure. So in this case, I'm showing all of the wrong things to do. I have the machine positioned back out towards you, the audience person watching this. So I have to face away from the patient to do the procedure. The patient themselves are sat partly upright with their arm turned back in towards their body. And this creates a lot of different angles and a lot of challenges to getting that IV placed. And so for the most part, we want to optimize things and place the machine in a spot that's easy to look at. Have the patient lie down with their arm out flat so that we minimize the number of angles that we have to deal with as we place the catheter. And make sure that everyone is comfortable. You should be able to both move your hands around comfortably in front of you, be able to see the machine comfortably, and the patient should be relatively comfortable as well. Again, when we're gripping the probe, we want to use what I would call a pencil grip, where we're kind of holding the probe with our thumb and index and middle fingers, and then have our other fingers or the side of our hand along the patient's body to keep the probe from sliding around. Traditionally, when we're putting in peripheral IVs, we use kind of an over-the-top catheter grip so that we can use our index finger to push the catheter off the needle into the vein. But for ultrasound-guided IVs, that technique often backfires on you. As we go through so much more tissue for the ultrasound IVs, oftentimes as you go to advance that catheter with your index finger, what you actually do is back the needle out, and unfortunately your catheter won't get into that vein. So a lot of times I recommend an under the catheter grip so that you can again take a more steep approach at the vein and really be able to kind of control it a little bit better. In terms of the veins that we're interested in, for adults, most of the time we're going to be working either with the proximal forearm, so near the antecubital fossa, or actually in the antecubital fossa with the brachial vein, or the basilic vein, which is along the medial aspect of the arm at the elbow, just above the medial epicondyle. In children, a great target is the saphenous vein at the ankle, both because it's away from their arms, where we don't always like to be putting in these IVs, and because in terms of a child who's unwilling to be cooperative, it's an area where we can often get fairly good control of their limb and be able to hold their legs still for the procedure. If necessary, we can do the forearm and the antecubital fossa. Typically, we would prefer to do the forearm in pediatric patients. Once we identify our site, we need to take a look for veins that may be candidates for cannulation, and we need to distinguish them from the arteries. If you press gently with the ultrasound probe, you'll find that the veins collapse pretty quickly and the arteries collapse more slowly. It is important to note that arteries will collapse if you push hard enough, and so you need to push gently and look for that arterial pulsation and make sure that it's not an artery that you're planning to cannulate. And so, for example, here we go with some kind of gentle compression. If we push just really gently, you'll see that, oops, I slowed it down. We'll get that back going here. So again, if you push, relatively gently, you can see that the veins will collapse and the artery will stay open. But again, important to note, please do remember that if you push hard enough, even that artery is collapsible. And so you really want to just kind of gently press down with the probe to see if the veins will collapse. If there's still some confusion about whether or not there are arteries or veins, you can turn the color Doppler function on of the machine and look for pulsatile flow. In the short axis view, the flow itself may or may not look red or blue depending on how you're holding the probe, so it's more important to look for the character of the probe. In this case, you can see that middle vessel has some pulsatile flow. The vessels on the sides aren't showing really any flow at all in the image that we're looking at, and that will help us determine the arteries from the veins. The arm at the elbow has a number of different good candidate vessels. Usually in the more superficial tissues along the medial aspect of the arm, so in towards the body, will be the basilic vein. It is fairly reliable in that most patients will have a basilic vein. It tends to be moderately large compared to other veins, and so it makes for a good target. It's important to note that if your patient may need a fistula or a PICC line or other durable access in the future, that placing an IV in that location may prevent other attempts at placing catheters in those veins. So for those patients, that would be a consideration. The other thing that's important to note is which direction the vessel is headed. So sometimes your target vessel starts to move sideways across the arm, especially at the antecubital fossa as veins turn to move around the biceps muscle. And so you want to just follow that vein with the probe and make sure you get it lined up really nicely to make sure that you can tell where it's going. So in this case, we're kind of following this vein up, and we can see that it starts to turn, and so as we move the probe, we can get kind of lined up over it. So if we're doing a transverse approach or an out-of-plane approach, we want to try to keep the target in the middle of the probe. We want to keep the probe itself perpendicular to the skin, so standing up nice and tall on the arm and not tilted, looking at an angle into the tissue. As we start the needle in, we're going to move the probe back towards the needle, so bring it back towards us, the operator, to make sure we find the needle tip, and then we'll slowly move the probe forward towards our target and move the needle forward in little increments. So we always keep the needle tip in view even though we're doing an out-of-plane approach to the vessel. So that looks like this. We start the needle in, and we move the probe back till we see the tip, and there it is. And then we move the probe forward and move the needle into the picture, move the probe forward, move the needle into the picture, over and over again as we get down towards the vessel. So this is the loop starting again, kind of inch in towards it, inch in towards it. And when we do our hands-on session, we'll go ahead and be practicing that. If we're doing an in-plane approach or a long axis approach, those are the two names for the same thing. We're going to go ahead and still identify our target in the short axis view, but then turn the probe to get that vessel into a long axis view or an in-plane view before we start our needle into the tissue, into the skin. When we do, we're going to start the needle right in on the end of the probe and then bring the needle right under the probe into our target. So here we go. We've got the needle coming into the target, and we're just going to kind of advance it farther into the target vessel, and then we'll be putting the catheter off into the vein. It's important once you're near your target not to take your eyes off of the screen and look at your hands. It's important to really keep your eyes on the screen and really try to keep your eye on the tip of the needle, and much as you can, advance that tip into the vessel as far as it will go before you try to move your catheter off into the vein. So one of the big issues and the reasons for that is that the catheter will give you a flash well before you're ready to put the catheter off the needle into the vein. So the tip will give a flash in this left-hand image as soon as it punctures the top wall. But given all the extra tissue on top of the vein, trying to push the catheter off is really just going to push that vein all over the place, and the catheter won't actually end up inside the lumen. So what we want to do is move the needle even farther into the vein, as in the right-hand image, before we try to push the catheter off. And that will make sure the catheter is really going to be inside that vein before we try to move the catheter off the needle. Same issue here. On the left, we're just barely in, and on the right, we're going to kind of move that needle tip down into the vein several more hops before we go and push the catheter off. Unfortunately, this is a difficult procedure to master, and so you will find that, especially as you're learning it, you'll have failures, and that is to be expected. In the case where you feel like you've got a flash and you've advanced your catheter off, but you don't get any more blood back, a lot of times it's because the needle tip either did not end up where you thought it was, or again, you pushed the angiocath off too soon and the catheter itself kind of forced the vein away from the needle tip and never really made it into the vein. Sometimes you'll have a case where the catheter will back out of the skin, and again, oftentimes it means that your catheter was too short, or you squished their tissue together with the probe, made it look like there was enough distance to get into that vein, but when the probe was removed, their skin fluffed back out and backed your catheter out of the vein. And then, of course, unfortunately, the last most common reason is that the catheter came dislodged because of the patient moving around, or we just did not get it stuck down properly in the first place. If you are successful in placing the IV, you should be able to get blood back out of it pretty easily, and it should flush really easily. There should not be any swelling at the insertion site. However, you should understand that extravasation from these catheters takes quite a while to become apparent because they're so much deeper into the tissue. That tissue can accommodate a lot more extravasation before there's really a palpable mass to note. And so it's not unusual in adult patients to have 250 cc's of saline go through an extravasated IV before really the patient notices something and mentions something. So finally, it's always important to dispose of any sharps. Please don't leave those for someone else to do. Please take care of those yourself. When you finish the procedure, you'll need to clean any gel from the insertion site very carefully. It's not unusual to dislodge the catheter here while you're trying to clean up the gel from the procedure. Typically, I use an alcohol pad and just gently scrub at the skin to make sure it's all off. If there's any residue at all, it tends to prevent the dressing from adhering very well. If there are samples that are obtained, make sure you go ahead and label those. And lastly, let's make sure that we leave the patient's embedding clean so that the patient can have a nice, clean environment. That concludes this module. If you need to schedule a time to come into the center for a practice session with our phantoms and ultrasound machines, please let us know. Otherwise, enjoy and good luck.